The first is that I want to begin, as we do everything here, with a land acknowledgement. And I wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it's been home to Indigenous peoples, the Huron-Wendat, the Seneca, and most recently the Mississaugas of the New Credit. It is still home today to Indigenous peoples from across Turtle Island, and we're grateful for the opportunity to work on this land. Okay. The BOEM lecture series is an opportunity for us to show off some of the very exciting scholars doing really important work here at the school. It's also a chance for us to take on a different role, and that's to be a forum where we can bring not only our best, but also the best from around the world to bring up and put on the agenda topics that need to be central to where our health system's going. And I'm really grateful for that. I'll want to just take 1 second here and acknowledge Les Boehm, who I'm looking for in the audience. Where's Les? Thank you, Les. So, Les is one of these people who likes to see things get done. And so Les came to me with an idea and said, we should do something about actually making the school a place for dialogue and discussion, for actually trying to change and shape the discussion on health policy. And of course, in proper academic administrator fashion, I kind of nodded thoughtfully and said yes. And then Les kind of upped the stakes and said, well, I'm willing to support this too. And so thank you, Les, for forcing us to do this. It's a great thing for the school, and I know we're all grateful for it. I want to talk for a second just about the theme. So for years, Canada has been in the lead on thinking about the social determinants, and it has been dead last in actually doing something about it. And we have tolerated our healthcare system and our social system as the proverbial two solitudes that never have to meet. But I think now when we look at, not only where we'd like our health system to go, but the challenges that we face in what people need to truly stay healthy, we can no longer keep these things apart. And so today we're going to talk about the role of the health system in bringing these two solitudes together, and to look at two cities. We've entitled this talk, A Tale of Two Cities, to look at two cities of New York and Toronto, and what they've actually done to bring this together. Now, one of the nice things about being a Canadian health policy scholar is that we can always look slightly south of the border and kind of look down our nose a bit, right? At least it's not the US, right? I think the days of being able to do that, and surprisingly, when we get to issues of equity and we get to issues of social determinants of health, are starting to slip through our fingers. And so while we've been able to tolerate it, because we are in many ways a very lucky country, we've been able to tolerate this divide for a long time, that time is fast fading. And so I'm really grateful for all of our speakers who Professor Arjman Siddiqui will introduce after her remarks. Now, just one last thing for me to do, and that's to actually introduce Professor Arjman Siddiqui. So I have a long bio here, and I could actually read an even longer bio out here. Let me just deal with a couple quick things. So she is the Canada Research Chair in Population Health Equity. She's very clearly one of our faculty. She holds appointments a number of other places. She is a Harvard grad, and I can keep on adding all these things that signify achievement. She's not only a Harvard grad, but we lured her back to Canada, which I'm always grateful for. But what I'll say personally about Arjman is that she's one of these people who you really value in your life, who has rigor in how she looks at questions. She has a relentless curiosity in how she looks at issues. And she has a passion for actually taking both of those characteristics and trying to turn it into the pursuit of a more just society. And so I often find myself turning to Arjman for advice when I don't understand something or I know that I need to probe deeper. And I'm always impressed not only with the thoughtfulness, but actually the usefulness of what she tells me as well, and I know that she'll be doing that again tonight. With that, I'll just say thanks to Annette, to Francoise, and their teams for what they've done to actually make tonight a success. The fact that we're almost full and that I'm always anxious about a visit from the fire marshal is a very good thing, so thank you. And Arjman, I'll turn it over to you. Thanks a lot.
I'm not above drinking half-drinking water. Is it okay? Fresh water. That's fine. Either one. Thank you. Thanks so much, everyone. Thanks for coming, and thank you, Steny, for such kind remarks. I sort of think about serious research and nutty research. And sometimes what I do is seriously nutty research. And I have to say, I have never, ever felt the need to constrain anything I do because of the academic freedom that I think Staney holds so dearly. And I very much appreciate the fact that we're able to pursue what we want to pursue. Okay, so I am going to try to give us a very big picture context for the rich discussion we're about to hear. So what I'd like to do is talk a little bit about what you see when you reflect on health in Canada and the United States, and do so in a comparative way. So if you first take a look at a broader lens, the broader set of comparable societies, the OECD, longstanding OECDs, these are the sort of economically advanced, arguably democratic countries of the world, you can see a few things. One is that over time, there's been a steady increase in life expectancy across these countries. You can also see that they are relatively clustered, but that there are distinctions amongst them. So again, these are all countries that have the resources, have the institutional stability to be providing as much support as they can for the health of their citizenry, and yet you see that there are some clear distinctions in their, in this case, life expectancy. And these numbers may not seem that distinct, but they in fact are. If you look more closely at the Canada-US comparison, you'll see that in 1980, a gap opened up, a Canadian life expectancy advantage opened up, and it was about a difference of about 2 years. 2 years is about a 50% difference in mortality in any given sort of age group. So it's quite significant that you have this 2-year gap amongst, between these two countries. And so one of the questions we might want to understand, if what we want to know is how can health be improved in societies? What can we learn when we compare societies that are both wealthy, have the resources, and yet have these divergent health trends? We might want to know what it is about these societies that's leading to these distinct health trajectories. So one question you might want to ask is whether these societies actually are the same or are different institutionally in terms of their resources. And there's a political philosopher who often tells me that if you ask Canadians what forms their identity, what are the sort of central tenets of being Canadian, a lot of Canadians, in the, sort of the top 10 answers will be the fact that we're not American. So we seem to be distinctly proud of that fact. This is a picture from a beer commercial from the 2000s where they sort of capitalized on this idea and did a whole sort of sequence of things where they defined what it was to be Canadian in opposition to being American, and Sheila Copps at the time sort of said it's sort of self-validating to contrast ourselves with Americans. In fact, we do have a lot of similarities that we often sort of overlook. The origins of our countries are very similar. We both started with a violent history, a history of subjugation of indigenous peoples, appropriation of land, and violence against people. We started with a history of slavery very early on. Of course, it was much more systematic in the US because of the tie between slavery and the plantation-based economy there. But nonetheless, these were both features of both Canadian and US society. This is more recent data that we put together a few years back where we showed how differences of experiences of discrimination appear in Canada across racial groups. So in each case, from going from left to right, these are different types of discrimination, reporting that you receive less courtesy or respect, poorer service, are treated as not as smart, or are feared by others. And in each case, we've compared racial groups, non-white racial groups against whites. And you can see that in each case, Indigenous and Black groups report far higher experiences of discrimination in Canada, and this is also what you see in the US as well. So one might conclude then that another similarity between these two countries is that the quest for reparations and the demand for reparations is, as it should be, alive and well, and is something that the government should respond to quickly. On the far left-hand corner is Marianne Williamson, who is often sort of dismissed as a quack, and she's a candidate for the Democratic primary, but she is in fact the person with the most robust reparations platform amongst the Democratic candidates, and it's been receiving considerable attention by several US economists. Another similarity between these two countries is that in the 1960s, they both opened up their immigration strategy to attract immigrants from Asia and Africa, where before that era, most immigrants had come from Europe. And so you have two societies that have very rich racial and ethnic diversity by virtue of their origins and also by virtue of immigration strategies that sort of paralleled each other in terms of the trajectories they followed. Finally, if you look at the larger set of societies that I presented earlier, the sort of wealthy democracies, they cluster into what political sociologists have called welfare regimes, which describes the kinds of social policy orientations they have. It describes who they put the emphasis on in terms of responsibility for social welfare. And Canada and the US both cluster into liberal welfare regime type. And that signifies that in both societies, the responsibility for social welfare, for income, for housing, for healthcare, and so on, is largely relegated to the market, meaning your individual market position, your labor market position, and so on, is a primary means for acquiring the basic goods and necessities of life, in contrast to a Sweden, where social policies are much more oriented to government responsibility for basic needs. So there are some similarities between the two countries, and yet we see these health distinctions, and moreover, not just a temporary distinction, but really a long-term now trajectory of a Canadian advantage in health. So the question is, why do we see that? Well, a good place to start looking for answers is the World Health Organization framework on the determinants of health. And the framework essentially teaches us that the things we routinely talk about in public health, health behaviors, whether you're exposed to environmental toxins, what kind of healthcare access you have, and so on and so forth, are ultimately decided by more upstream factors, notably by what we call the social determinants of health, your class, your race, your immigrant status, your gender, and those are in turn shaped by the kinds of policies that I mentioned earlier, the welfare giving policies. And so if we want to understand why Canada and the US are different, we can quibble about whether one has better health behaviors or not, and so on and so forth. But really what we want to know is, what are the upstream factors that are differentiating these societies? Because it's the upstream factors that will get us to the root cause of the matter. So let's go through a few explanations. The first is perhaps the most intuitive, which is that we have differences in our healthcare systems. So if we were to use this framework as a guide, this would be like saying that this pathway, this access to healthcare pathway, is really what's leading to Canada-US differences, and the corollary is that it's healthcare policy from the upstream perspective that's producing these differences. There was a paper a while back which looked at the relative contribution of various determinants of health. And it essentially wanted to answer this question: how much sickness or death could be averted in the US if there were universal health care. That's a different way of asking this question of how much is health care actually causing health itself. And what it found, as it looked across studies, is that the answer is not very much. Healthcare is wonderful. We should have a right to healthcare. It's great to have healthcare when you're sick. But to understand why two populations are differentially healthy, healthcare doesn't seem to go very far in explaining that. And we think that's because it doesn't dictate who gets sick in the first place or the factors that make us sick in the first place. So is the Canadian health advantage because of our universal health care? Stunningly, we think no, it's not. What's the second possible explanation? Well, maybe it's that we are a richer society. So these are both richer societies, but maybe what's happening is that overall we are sort of economically better off. And so in this framework, it would be the idea that the most root cause is our overall economic well-being. Well, if you look at indicators of economic well-being, you'll see that, again, it's not what you would expect based on the Canadian health advantage. The top line, the blue line there, is the GDP, the gross domestic product growth in the US over time, and the red line is Canada, the black is the OECD average. And what's really interesting is that the US opens up a GDP advantage at precisely the time it loses in life expectancy. So 1980 is about the point that Canada starts its steady advantage in life expectancy, and it's about the point that it starts its steady disadvantage in terms of overall income. If you look at graphs of the relationship between income and life expectancy, most of the wealthy countries fall on that flat part of the curvilinear association, meaning that when you get richer after a certain point, it's not making societies healthier. If you look at something like the unemployment rate, stunningly, you see similar things. It's a little bit noisy, but Canada actually has higher unemployment rates for much of the period that it sustains a health advantage. So these overall indicators of how we're doing economically do not seem to correlate to the fact that Canada has a health advantage. So what's a third possible reason? Well, there's a lot of compelling evidence from people like Lincoln Phelan that actually what's going on is not about overall average economic conditions, but the economic and social welfare of individuals and how different that is across a society, within a society. In other words, how big the inequalities are in our economic and social well-being. And so the idea is that if we look upstream, what we should be looking at are the kinds of policies that provide economic security and reduce inequality. So this is where you start to see some traction, and this is a graph of overall income inequality, and the top set of lines are market Ginies, meaning the level of income inequality just based on what people earn, and the bottom set are after-tax Ginies, meaning this is the kind of income inequality we see after we send in our taxes and do some redistribution. And in both cases, what you see is that Canada has maintained lower levels of income inequality. Even as US society has gotten richer, it's become more unequal. We've maintained relative to the US at least, relatively low income inequality. It's also true for poverty rates. You see far lower poverty rates in Canada than you do in the United States throughout this period. It's also true if you look at things like social assistance. Social assistance is the sort of income supplement we give to low-income earners. Canada's is nothing to write home about, but it is certainly better than what you see in the US, which gives lower amounts to people. It has more limited distribution. In other words, the number of people who are eligible for social assistance is much lower in the US. There are more work requirements attached to social assistance in the US, and so on. So in many cases, what we are seeing is that the best correlative features of society to explain the Canadian health advantage seem to be the fact that Canada does a better job of maintaining less inequality than the US. You can see this play out when you look at health inequalities. This is a graph of socioeconomic inequalities in obesity in both countries. And on the left-hand side, you'll see that US rates of obesity are higher in every quintile, but that the differences across quintiles are also much larger than the differences across quintiles in Canada. We see differences in racial health inequities in Canada and the US, and I'll just zero in on an example. This is hypertension. We still see black-white inequalities in hypertension in Canada. They're a bit more mitigated than they are in the US, and one strong possibility is not that actually we're better on race, but that we're better on class, which tends to be a factor in racial inequalities. So I think what we're seeing is a strong hypothesis that says health inequalities are lower in Canada, ergo our average population health indicators are better. So lower health inequalities lead to better average health indicators. But before we get too excited about this, we are seeing health inequalities in both societies are widening. On the left is work done by Veras Story, who was a doctoral student here at Dalla Lana and is now a postdoc at IWH. He's doing incredibly innovative work to understand the kinds of dynamics I've talked about today. And you can see that on the right-hand side of that graph, the lines are more disparate. That means across income groups, you're really seeing some big differences in mortality and life expectancy that you didn't see at earlier points in time. True on the right-hand side of graphs, which is the US, everyone's gaining, but they're gaining differentially, and so the inequalities between groups are widening. And if you go back to this graph, you can see why, which is that over time, income inequality is rising. We're doing less and less to reduce economic inequality. Government provisions of income and other social resources have dwindled in both countries. These are pictures of people who were pivotal in reducing the amount of social assistance received in the US on the left and in Canada on the right. It's not just Stephen Harper. This has been happening since the 1990s. Austerity has carried the day, as has been written, and the same can be said in the United States. And that brings me to what we're talking about today, which is that against this backdrop, the health system is essentially saying, what can we do? We recognize that these social resources are central to health, that it's not just healthcare. We see societies where governments are playing less active and even some damaging roles in providing basic goods and services. And what we're going to hear about tonight are two examples of where medical systems have been active in trying to essentially make up for what broader society isn't doing with any robustness anymore. So before we hear from our speakers, I'd like to tell you that we're very lucky today to have a perspective from a patient advocate as well. So I can tell you lots as a researcher, but it would be really nice to hear what people are experiencing in real time, in real life. So let me introduce to you Vera Story, who is a master's candidate in poverty reduction policy at SOAS University of London, and a community activist with 15 plus years of experience. She specializes in creating social change via outreach and coordination, and her focus lies at the intersectionality of social determinants of health and health outcomes. She's a member of Ontario Health's Patient, Family, and Public Advisors Council and was awarded Most Promising Young Innovator at the 2018 Active Citizens Social Enterprise Summit for her app concept simplifying the hiring of people with disabilities. Her personal experience with chronic illness and disability have now led her to create a social impact project that focuses on reducing inequalities through empathy creation and generating liminal shifts in societal awareness. Vera has worked with several federal government departments and nonprofit organizations and has volunteered with many organizations on issues ranging from genocide prevention to Canadian newcomer integration. Please help me welcome Vera.
Good evening, everyone. I hope you're all keeping warm. In 2010, I was completing my studies at Ottawa when the aches and pains I had been experiencing since my teens became far worse. Every day I attended class with fevers, and I often topped up my week by going to the local clinic where doctors would tell me, if you're having a fever, just take Tylenol, it will wear off. One week from that summer stands out when a female doctor actively listened to me for once and then asked me, have you ever wondered if this could be lupus? Less than 2 weeks later, I received results telling me I was ANA positive. Though I now had trouble breathing and walking, I was told it would be up to a year until I could see a rheumatologist in Ottawa. I decided to take the train back to Ajax, and my family took me to 3 different ERs until I was finally referred to Toronto Western Hospital by ambulance. That day, I heard one doctor said to another, this young woman has lupus and her body is shutting down, but we will keep her out of the ICU. I must say they held fast to their word, and were it not for Western Clinic, I would not be here today. Although I am truly grateful for the Canadian healthcare system, the fact stands that it took 4 hospitals, 15 doctors, and a few $100s to attain a diagnosis that saved my life. More importantly, I had to find doctors who would take me seriously. If I had not had a supportive social system to help me financially and even physically at times, I would never have left Ottawa and I would not be alive today. My years as an advocate have taught me that not only is my story common, but I'm one of the lucky ones. Those living in rural areas often have a far larger fight to face. Many of my fellow patient advocates live in Northern Ontario, and they must be prepared to drive up to 8 hours to meet specialists that can only be found in a city like Toronto. This is an even greater problem than one might think when the government feels that they cannot find a strong justification to fix the roads up there. Additionally, the Northern Health Travel Grant, which is meant to offset the cost of health-related travel for those living in Northern Ontario, requires that hotels be paid upfront even when you're living in poverty. I have also been told that recent government cutbacks have meant that local health centers in the north have lost key administrative and medical staff. Slashing the number of health centers has also meant traveling farther and farther, even for a flu shot. Wait times to see specialists are exorbitant, with more than a 2-year wait for psychiatrists, even in towns with a large proportion of addiction, poverty, and mental health issues. How can the social determinants of health be addressed when basic health care is being rolled back? Do governments not understand that treating patients properly will mean less hospital visits in the future and less people on welfare as their health improve? At a recent meeting of patient advocates, a group of healthcare evaluators asked us, what would you like to know about a hospital before you go there? Would any indicators on patient safety or infection rates help you decide? And most of my fellow rural resident advocates scoffed at the questions because they don't have that choice. They have to go to the hospital nearest to them or go to none at all. Another advocate asked if we would even be able to access those indicators, as some of our own patient data is censored from us, even though it would allow us to make better healthcare choices in the future. A great united fear that all of us patients have is that any improvements that are not enshrined in law will simply be rolled back by less understanding governments down the road. Canadians have much to be thankful when it comes to our healthcare system. There have been countless times that I've visited a hospital with nothing asked from me but my health card. However, the more complicated your health is, the more complicated the system becomes. While large hospitals, nonprofits, and other such groups in Southern Ontario may be taking positive steps to secure housing for citizens in need, what is needed in addition is a consistent standard of care province and countrywide, rural or urban. Innovations can come from any sector of society, and they are welcome, but it is the government who must preserve these ideas in policy and law. Thank you very much.
It's now my pleasure to introduce tonight's featured panelists. First, Dr. Dave Chokshi is a population health officer at New York City Health Plus Hospitals, the largest public health care system in the U.S. He also serves as Chief Executive Officer of the H&H Accountable Care Organization. His focus is on health system improvement, spanning innovative care models, population health analytics, primary care transformation, disease prevention, social determinants of health, care management, and implementation research. I'm already tired. His prior work experience spans the public, private, and nonprofit sectors, including positions with the New York City and State Departments of Health, the Louisiana Department of Health, a startup clinical software company, and the nonprofit Universities Allied for Essential Medicines. Dr. Chokshi received his MD with Alpha Omega Alpha distinction from the University of Pennsylvania, earned an MSc in Global Public Health as a Rhodes Scholar at Oxford, and graduated summa cum laude from Duke University, and GTHD is all I have to say to you as a Carolina affiliate. Dr. Andrew Buzari is a primary care physician and executive director, health and social policy at the University Health Network. He holds academic appointments as an assistant professor in the Department of Health Policy Management and Evaluation at the University of Toronto, and as an adjunct faculty member at the Mailman School of Public Health at Columbia University. At UHN, Dr. Buzari is working to help to develop, evaluate, and scale new models of healthcare delivery for patients with complex health and social needs. Prior to joining UHN, Dr. Buzari served in senior advisory roles in the provincial and federal government on public policy issues ranging from primary care reform to the implementation of pharmacare. Dr. Buzari completed his medical training at the University of Toronto and earned his master's in public policy at Princeton University and his MSc at Harvard University. He has maintained active research as a visiting scientist at the Harvard T.H. Chan, I say T.C., I don't know why, but T.H. Chan School of Public Health, and is a senior fellow at the Wellesley Institute. I even had to correct that on my CV. Welcome to you both.
Days at the end.
Oh. What should I do?
Not at the first spot. Andrew's in the middle.
Is this going to come down at all or no?
No, it's going to stay up right there, right?
Thank you. Okay, so why don't we start with some time for your thoughts, your comments, and then we can maybe launch into a discussion.
You're the guest.
Well, I have to start by saying I have a tiny glimpse into what it must feel like to be the American ambassador to Canada. And so I feel like I have to begin with some sort of grand apology. But let me skip over that, although I'm sure there will be occasion to come back to it. I thought I would start really by picking up where Vera left off with her very thoughtful comments. And my entry point into this conversation is, first as a clinician, as a doctor. And I think about the patients that I see. I'm a primary care physician. I practice at Bellevue Hospital, which is one of the public hospitals in New York City. And there's not a single clinic session that goes by where I don't feel the downstream consequences of the structures and the systems that Professor Siddiqui was talking about. So, I can sort of call to mind specific patients who really conjure that up for me. So a patient who has had longstanding diabetes, whom I've been taking care of for almost all of the 6 years that I've been practicing at Bellevue, whose blood sugar I have never been able to get under control over all of that time. And has very little to do with the medicine that I prescribe or don't prescribe. It has to do with the fact that he is reluctant to start insulin because he lives in a homeless shelter and has no place to refrigerate his insulin. Or I think about another patient who has now advanced liver disease related to alcohol use disorder. And I've sort of seen him through the ebbs and flows of his condition, and it doesn't take a scientist to pick up on the fact that the times that his alcohol use disorder is worst for him is when he's not employed. Those two things go hand in hand, for him. And so there are countless stories like that, that I'm exposed to as a doctor, that I'm sure Andrew is as well, and other clinicians in the room that I think should force us to confront the social determinants of health in the way that Professor Siddiqui has laid out. So I don't want to go on for too long in my opening comments. I think just to tie it to one other point that was made in the opening remarks, which is that it does sort of beg the question, why are we even talking about healthcare and health systems given the small contribution that clinical care has to health outcomes? And I'll just share again maybe a very personal perspective because I know there are some students in the room as well. After I finished my long pipeline of clinical training and I sort of came to medicine with this public health heart, believing in health as a way to get to opportunity and to try to address justice in what I saw was wrong in the world. And so after I finished my training to become a doctor, I said, how do I arc back to that? And there are many different paths, and everyone should make his or her own choice. But one of the reasons that I chose to embed myself in the healthcare system was this simple fact. In the United States, $3.7 trillion flows through the healthcare system. And so the resources that are allocated and the decisions about how those resources are allocated offer a tremendous opportunity for us to try to do better. And so, some of the work that I hope I'll have a little bit more of a chance to talk about is about making the case from within the healthcare system how healthcare should be more relevant to the health of patients, like the ones that I described.
I guess I'll try to figure out if I get the mic right. I think, Dave, thank you so much for coming up. I think we've talked about this for a few years, and I appreciate you coming up, especially as you're a new dad and everything else that's happening on in the city. And thank you to everyone for putting it together and all the work going into it. So I think from my sense of starting on the views, is that I come at this probably from a place of humility of the people who are in the room and the people who've allowed for this work to take shape. I think that, as Professor Siddiqui laid out so compellingly, that, it is, I do have to acknowledge the discomfort that for us as employees of hospitals, talking about the social determinants of health as this sort of novel issue for us to tackle, when since 1974, 75 in Canada from Milan, we've laid it out internationally for folks, really have to have that sense of humility that we're incredibly late to the game as the acute care and hospital networks about trying to understand the social and structural determinants that Dave and others have laid out today. But I think the argument, too, that I would try to push on a little bit is Professor Siddiqui's laid out. We've known about these disparities for 30, 40 years. We see the graphs from the 80s. And we see it in health outcomes, but we also see it in healthcare inequities for access. So whether it's colorectal cancer screening, whether it's cervical cancer screening across neighborhoods, we've known about these disparities by income of poor, Black, or Indigenous communities and people's not having access to services. And so the argument that I would make is we've, as a healthcare system, have discriminated against people in poverty. And that's as a system. And I think when you look at that data for 30, 40 years, and again, it's not to be the downer skunk at the lawn party for using the American, but I think the issue is that has been brought forward for Canadians is that this is what we have to grapple with is, I think the term was used, tolerance. And then we push it and say this has been discrimination, that we've known these things for this long. We have not acted convincingly as a healthcare system. When you think about the dollars that we spend, it's not 3.7 trillion, but the latest budget projection for the ministry in Ontario is $63.5 billion. And that's what's been used, and how much of that is actually going to driving health outcomes, 10 to 20% or so forth. And of that 10 to 20%, we've accepted 10, 20, 30% disparities in access to things that ostensibly have no copays, have no direct financial obstacles. And so I think that's where, I think as a hospital or as a primary care provider, that's the piece I think we have to move to. Not talk about the social determinants of health. We've known about it since 75 or earlier. What's that moral imperative? What's that piece now is saying, are we going to accept as a country, as a society, that we are having 20 to 30% disparity gaps on things that we should offer that already finance, and even I think more harrowingly, the health outcomes and life expectancy outcomes that we know across the country from both urban or rural, or across different racialized and disadvantaged populations. I think that's the position that I come to this conversation at this point after whatever set of experiences over the last few years.
Great, thank you both. So I think this is sort of a self-indulgent question, but something I've wondered about. What is your sense of what changed in medicine, in the healthcare world, to make people think we should move from awareness that these inequities exist to actually acting on something other than clinical care and sort of evolving into some of the initiatives that I hope you'll both sort of describe for our audience tonight that have a lot to do with things that before were sort of, not even on the radar of healthcare systems.
It's a great question. I think, well, first I would echo what Andrew said, which is we should approach this from a position of humility and recognizing that in many ways this is just the resurgence of a conversation that has happened before. In the United States, the community health center movement that started in the 1960s was really founded upon this same idea. They didn't use the term social determinants of health, but that is fundamentally, what it was about. And of course, we should acknowledge that the community health center movement in the United States actually drew its roots from community health centers that started in South Africa. So actually the lineage of these ideas, I think they do have deep roots. But with that said, something has changed in the conversation over, I would say, the last decade or so. I can just give maybe the United States perspective on this, which is, I think it's two things. I think one, it is a testament to the power of research and the idea that rigorous research that is sort of coalesced into a story that feels right can actually influence public debate. And I think that a lot of what emerged in terms of the fundamental determinants of health and actually how small of a component clinical care was in contributing to health outcomes was because of studies that were published in in the 1990s and the 2000s. So that's one piece of it. The other one is really a little bit more brass tacks. It has to do with financing, with the dollars. And in the United States, and I know there's there are parallel conversations happening in Canada, there is a movement around value-based payment and value-based care, which is really to say, well, when we look at all of these graphs of how much money and resources we're allocating to healthcare, what is the value that we're truly getting for it? And so, in the simplest formulation, value-based payment is just saying, well, shouldn't we be delivering better health outcomes for the dollars that we're spending? And that forces a conversation about what are the most effective investments, again, if the goal is health and not just delivering services. So I think that has really pushed the conversation forward. And the final thing that I'll say is that I'm really heartened by it. I think there are a lot of people who feel like this phrase, the social determinants of health, has almost devolved into a buzzword that is becoming less and less meaningful. And I think there's some reality to that. I would just caution that we should have sort of a big tent approach to it, right? And the fact that more and more people are talking about it, even though it's perhaps not with the same precision, with the understanding of people who are in rooms like these, is an opportunity for us to change minds and actually get people to think differently about how to make investments, whether it's through the healthcare system or macroeconomically.
Great, thank you. Dr. Bizzari.
Yeah, I mean, I won't, take the cynic view, but I know that obviously where we're situated in the university, absolutely, and I agree that I think decades of great research and evaluation has definitely allowed this to open. But I'd also be remiss not to mention when you've got a leader like Camille Orridge and you're talking about a tale of two cities who've been there in terms of where the community has been on these issues, not only decades ahead of us, but pushing issues in terms of where hospitals, 10 to 15 years ago, by things like health equity screening or to advance sociodemographic data, we had to be thinking about it. But I would argue as well that I think that, why we're starting to act now, or trying to act in ways, sometimes it causes, I think it's probably a confluence of things, but, I do also want to probably get at, maybe not, again, not to be too cynical, but I do think the policy incentive pieces are really important. And I think, not to speak for the American experience, but having a brief visit in time in the U.S., I think the Affordable Care Act on issues around thinking about financial penalties for hospital readmissions and issues where there might have actually been cost savings where hospital CEOs, to avoid a 3% hit, could say we'd actually make those investments in housing and pay for people's rent, and we'd probably still come out positive in terms of our budget at the end of the year. So I think that whether, whatever the case or intention to do it, the massive policy drivers and financial incentives in there, I think the challenge that I'm which everyone I think is seeing who's working in the system, is just how poorly aligned those incentives are for us to actually want to move into things about improving health and not think about healthcare. I mean, the experience that I think of, again, from a primary care lens, is when a previous administration wanted to invest in primary care with family health teams, there was no risk adjustment for social complexity and of issues of where we take on patients. And if you look at the great research and evaluation from ICES, the Institute for Clinical Value Sciences, they show that those investments poured into neighborhoods and communities for primary care where they were not the sickest and poorest patients. And so I think that pieces that get at, not to, again, get at some of the encouragement or curb some of that enthusiasm, but I do think pieces are, if we are going to see meaningful change, it has to be in partnership with community folks. It's not going to be hospital acute care led, but we also have to see governments not only on issues of healthcare, design incentives, design policy incentives that actually allow healthcare systems to do things that improve people's health. And I know I used the primary care example, but you go through a litany of others when it comes to issues like housing, issues that come into food insecurity, and everything else that has been laid out for issues about healthcare or health outcomes.
That's really helpful. I'd like to come back to the policy issue a little bit later, But for now, I'd love to hear what kinds of initiatives are happening that you think are moving from recognizing that social determinants matter, that there are health inequities, to the healthcare system actually actively engaging in addressing them. What are some of the developments that you find most compelling? And for that matter, what are some of the things, if there are any, that you think have been less helpful?
Go ahead, Andrew.
Sure. I think in terms of what we've been, in terms of that question, I think where we've probably seen some hope or help in terms of what we've been looking at interventions, and I think, again, I think one of the challenges, sorry, I'm always like, I'm being the negative person up here, but I feel like, Canadians, I think, as you said, that Joe Canadian example from Molson, I think for too long have had issues of, resting on laurels or looking at different outcomes. I think that the challenge for us, and I think on this when we're looking at even things that we could point to that we're doing well, and I'm sorry for the circuitous way to get there, but I do think in a single payer system where you think, again, ostensibly our biggest advantage should be data. When you think of all the national leadership and advocacy you put on the map, Professor Siddiqui, on trying to see that happen, we have really poor data about how and whom is suffering and how our actions are dealing with that. But I would rewind to say, when I first started at UHN, one of the first things we did to get to why we were thinking even about an affordable housing strategy, again, there's been great research across the country for years to tie housing to health, so this was not in any way a nascent move or in any way being at whatever leading edge. We saw a cluster of patients in low-income neighborhoods, especially in the Toronto Midwest area, that were coming with high ED visits, lots of admissions, and we've not actually ever really as an organization been thinking from a population health analytic view to say, who are our patients who are most in need? And if we don't even have sophisticated data for costs, how can we look at the proxy for volume to say that these are high needs patients? And we're underserving these patients instead of the usual view of our healthcare system where we said, these are frequent flyers, these are folks who are coming in. Nobody wants to spend Friday night at the emergency department if they don't have to be there. And those were things where I think the data was pretty compelling for us that these are clustered populations that we've not really looked at or decided to have a better sense. And then really quickly it was clear from the community that their leadership, and they've been doing that for 5 or 10 years in the area, was we don't have enough supportive and social housing. And what's UHN's role going to be in that? And that's where I think in terms of where the initiatives have come, it was really led by the community to say, where we have resources, where we have a role as an anchor institution, and to think differently about our $2 or $3 billion budget on the impacts that it has on communities. How can we actually dedicate those resources, not move into the housing piece, but say, here's where we know there's an impact not only in healthcare utilization, but hopefully on health outcomes. And I think that's one where, I think there's some promise. We really want to go with the cadence of where the community is in terms of any, future outcomes. But I think that's one piece where there's confidence because it marries some of the data to the patient experience and community leadership. And I think that would probably be the main example.
Great. Thanks, Dr.
That's
Hodge.
pretty optimistic, Andrew.
I turn around, turn around.
We began our journey in a similar way to what Andrew describes, and I would underline the point about having these solutions not emerge from boardrooms or even, exam rooms in the clinic, but really from people who are experiencing the conditions that we're talking about that lead to illness and poverty, and who can feel the vicious cycles that connect, those things in neighborhoods and in communities themselves. And so one of the ways that we tried to do that was there's actually a legal requirement for all hospital systems in the United States to do what's called a community health needs assessment. I remember being there actually, we do it every 3 years, so the first cycle of that was when I had first come to Health and Hospitals, and it was a very sort of straightforward community health needs assessment. We went out, we engaged our community advisory boards, but the way in which we asked the questions is really important. So the way that they asked the question was, what are the top diseases or illnesses, that you feel like are affecting your community? And so we got the answers that you would expect: high blood pressure and diabetes and mental illness and cancer. And so a few years ago, in sort of the next iteration of the community health needs assessment, we really pushed to say, look, this is a very sort of old-fashioned way of thinking about what generates health and illness. My mic just go out. I'll try to speak up a little bit. It's a very old-fashioned way of thinking about what generates health or illness. And so we said, let's actually try to push to what are called the causes of the causes.
This is a Canadian
No
high-tech.
problem. Sorry about that. To get to...
It's a BlackBerry, by the way.
Yeah. To get to what those fundamental factors are. And so what emerged from that was poverty and hunger, and the things that we talk about when we talk about the social determinants of health. And so it was very important for us to sort of go through that exercise to make the case that we needed to actually address those more fundamental causes. And so we then worked on elaborating our what we called a social determinant strategy, essentially growing out of that community health needs assessment. And so I'll give you sort of the broad brush framework and then a little bit more of the hard-nosed, okay, what did we actually do about it? So the broad brush framework was what I think of as the so what to the social determinants question. So that wonderful WHO framework that Professor Siddiqui put up in one of her slides, which some of you have probably seen before. I think it is a good explanatory framework. I think it should also challenge us to say, well, okay, so how are we actually going to do something about it? And so when we thought about it, we said, well, we have to sort of take that as the given. If we accept that framework, then we have to identify what our patients' social needs are, start to think about the social services, like sectoral solutions. It could be housing, it could be food pantries, whatever it is, to address those social needs. So you go from social needs to social services. Then what I think of as social care, which acknowledges that patients don't come in neat packages of only being food insecure or only being homeless, right? They come in complex bundles of physical health and behavioral health and social needs. And so social care, to me, is about addressing social factors in that context. And then ultimately going from social care to social justice, which acknowledges, again, that even that is not enough. When we're talking about structural inequities, like mass incarceration or racial discrimination, then you have to have a more political, you have to confront political choices for health. So that was kind of the overarching framework, and it was helpful for us to understand, okay, how are we going to put our chips on different parts of that, almost a continuum, to understand how to connect the dots between addressing individual social needs, but then having an eye toward, toward the broader policy and political milieu. And so just to, I'm sorry, I'm going on for a little bit on this, but I'll just give you sort of a flavor for then the more concrete part of it, which is we then took on 4 specific domains where we said we are going to look for very tangible interventions in these domains and figure out what works and how to make the case for investing in it for our patients. So we chose housing, food insecurity, legal services, really important, particularly for our patient population, many of whom are immigrants, many of whom are undocumented immigrants, and particularly in a political environment in the United States, which has become much more anti-immigrant in the current federal administration. So the third was legal services, and then the final is what we called income support, but which is really about how we can actually try to more directly address poverty. So So those are the 4 domains, and then we had specific interventions that we picked within each of them, which I'm happy to elaborate on, but maybe I'll leave it there for now.
I would love to hear an elaboration, but just before, I might ask Dr. Bizzari if you could say a little bit more about how, or to what degree did housing come out as the primary focus as opposed to other determinants, or do you feel like there was a discourse around that?
Yeah, no, it's a great question, because I think it's again, humbling on what actually gets taken up by people as interested. But I think that maybe to rewind on to the piece on housing, one of the things that I think which has been great from learning a lot more about the New York system and the public Medicaid system is just how closely aligned you are with the city of New York and the public health departments. I think one of the challenges, or one of the opportunities for us in acute care and the hospital networks has been, just like politics or good healthcare is local. And we've mostly, on University Ave, looked north to Queens Park on issues, or the ministry. And I think one of the fundamental differences or shifts that we sort of looked at was actually to go south to City Hall. And so one of the pieces that have allowed the underpinning for the housing initiative was actually to come together with the City of Toronto, Toronto Public Health, United Way, to sort of as an encapsulation of different community agencies and social service providers, to start to lay out what are some of those priorities in terms of issues of food insecurity, medical legal. And so that is where the social medicine initiative was coming forward in terms of how do we better listen to local needs and demands, both vis-a-vis municipal governments, but also from different community agencies, and then how do we enumerate sort of what some of these topic areas are. And we haven't come out with some of the other pieces that we're actively working on, because we really want to go at the cadence of co-design, which again can be really uncomfortable for hospitals who are used to doing things at whatever pace they think might be most effective at being done. And so this is a different pace, but I think I think this is an area that has been heartening on a different orientation from where we've been looking. And so on the housing piece, the reality was was land that a hospital had in an area where there's incredible amounts of, or there's a huge paucity of affordable and supportive housing. And how can we better contribute in this partnership to something to be done? So that's kind of where the housing pieces come forward. There's a bunch of different pieces on income as a major one. How can we start to better partner on issues around these sort of social needs that are coming up? And I think, as Dave has done, I think is great, is really trying to delineate between social needs and social determinants of health. I think we have a role, as folks in this room have done, in terms of healthcare advocacy, to push for issues about income inequality, poverty, and social justice. But then I think on the corollary is on the social needs. Those are the things that come with individuals that pour into emergency departments and primary care teams. So how can we better partner on those pieces, that we might have some ability with whatever resources we have that helps in the community and municipal government's efforts to alleviate some of that suffering.
That's great, thank you. So I'm going to go back to Dr. Chachki to sort of talk a little bit more in detail. And if you could weave in the process and the players, that would be really interesting. So I know Dr. Bizzari has just mentioned sort of a host of stakeholders that have been involved, community, nonprofit agencies, the government. I wondered if that's been your experience in New York, and I also wonder, what does it look like? Sort of, what are the negotiations that are happening? I imagine there are factions and there's people who are supportive, people who may be sort of more detractors, or at least prefer not to be involved. What is your experience of how this has evolved to allow you to focus on the areas that you mentioned?
Great. I'll pick up on housing, actually, because I think it's a very tangible example, for us as well. So housing is an area where the current CEO of Health and Hospitals, my boss, has been a real leader of this in the United States. His name is Mitch Katz, and I'm just going to channel him for a second, because what he says about housing is there's so few things in healthcare where you can identify the diagnosis and you have the ready cure. In this case, it's homelessness. The cure is housing, and it has no side effects. And it is both, true and transformative for patients' health. And I think housing lays bare, a lot of the issues that you're surfacing with your question, Professor Siddiqui. So I really admire what Andrew and UHN have done in terms of looking at land on hospital sites. We've done something similar. We have 1,500 units of housing for patients, both supportive and affordable housing for our patients across our different hospital sites. And in some ways, the symbolism of that is exactly what we should be going for, right? The name of my system is Health and Hospitals, and my tongue-in-cheek description of my job is we want more health and less hospitals, right? And so you're actually physically transforming a campus so that you don't have hospital beds because you're keeping people healthy by giving them housing. But it is not such a straight line path from one thing to the other. We're fortunate, our system, we're fortunate in many ways because we are essentially an extension of city government. So we are both a healthcare system, but also have direct connections to the housing agencies within municipal government. But I think a big part of the secret formula for success on any of this work goes back to where Andrew started, which is to have the humility to recognize that hospitals and healthcare systems are not actually the right places to lead much of this work. And that's tough for doctors to hear, for CEOs of hospitals to hear. But it is true to say that there are organizations, community groups, institutions who are far more trusted in the neighborhoods of the patients that we're trying to serve than hospitals and health systems often are. So we need to lean into that. But that requires, again, within the boardroom, the humility to say our reflex should not be we're going to do this all de novo and start it ourselves, but actually have the reflex to partner with others and allow them, in many cases, to take the lead. So again, to get a little bit more concrete about all of this, I'll tell you about a building that we opened up next to one of our Brooklyn hospitals last year, which was led by a community group called Communalites, which has been in the supportive and affordable housing business for decades, far longer than we have. And they helped us cobble together the partnership, some state funding, some city funding, our land, their ability to figure out what the wraparound services should be, in that building, and we were able to house, dozens of patients, 54 in our supportive housing units in that particular development. And I'll say, just to put the human, face on it, I remember going in there last summer after patients were actually, given the keys to their apartments, and it is so striking to kind of take what feels abstract in the years that it takes to development, and then sit down with someone and say, hey, how does it feel? And they tell you about the dignity that comes with being able to cook your own meal, on your stove, or to look in a mirror on your own bedroom door to adjust your clothes and to comb your hair, so that you feel like you have some dignity. And so, those things are supremely important, I think, to keep in mind with this work. The one thing, just to leaven it all a bit, is to acknowledge, that one building took 8 years from the time of project inception to a patient actually getting a unit. And it was about 87 patients who got housing through that. we see tens of thousands of homeless patients who cross our threshold every year. So I think the other thing it lays bare is we have to have a sense of scale in these conversations to understand that, yes, this is important for us to do. It makes sense for healthcare institutions to partner and to invest in it. But to get back to what you were saying, Professor Siddiqui, we have to hold the policy solutions and the need to advocate for different policy in our hands at the same time. I think about this again to move from housing to food insecurity just briefly. In my current job, I get pitched by a lot of health technology entrepreneurs who have their new whiz-bang app. And I can't tell you the number of people who are working on apps to better locate food banks, in the various communities. And at the same time, there's a policy debate in the United States happening where over 700,000 people are likely to be kicked off of their food benefits as a result of work requirements being proposed by the administration. We can't, this is the issue with the social determinants of health conversation, right? Too often there's this false equivalence between the scale of those two things, and I think that's something that is very important to check and keep in mind.
That's really helpful. So I won't pitch my app to you tonight.
Yes.
That's what I'm hearing. Dr. Bizzari, any thoughts on the process that you can provide for us in terms of how did this all transpire and what was the sort of lessons that you would take away?
Yeah, I think...
And where are you in the process, for that matter?
Yeah, the 8-year timeline was great to hear. So I think someone else here, look forward to you, seeing the completion of it. I think, again, I think going back to the process, I think it's a great point on recognizing the scale of what a healthcare-driven or resource is on the solution versus where the real social determinants lie with various levels of government. And I think really similarly, the thing that, I struggle with and I grapple with, is, and how you reconcile it is that, you can't shirk the responsibility of policymakers on issues of affordable housing, supportive housing, the homelessness crisis that we have in the city. And even if it is a 5-year process, it usually probably takes as long as your comparator, but say in half that time in 4 years. There's no way that this can acknowledge or even make a dent in the real issue that people in this winter are living with and will die from ultimately. And so I think that piece, has to be underscored of, yes, we've been moved to try to do something, and it's not to have this sense of skepticism. I think it's great to see various healthcare organizations, not just UHN, and for a long time, be pushing for these pieces and thinking about resources they might have that could be leveraged differently. But I think ultimately, we also have to think about the social spending piece. I know that graph was here about our healthcare dollar, and to Vera's points to put forward, I think what we struggle with is with the emergency department and hospital beds at 120%. There's probably detractors and people saying, does it make any sense for a hospital now to be thinking about or trying to do things on social terms of health when you can't even get the basics of healthcare right? And I think that's a really compelling argument. My view or take on that is, actually in a single payer system, that only underscores how important value is and what we spend on, because there is a massive societal opportunity cost. So when there's 30% of waste in the system, of course, the first and major issue is that you want the best patient experience, you want to avoid patient harm, you want quality of care. But when you look at $100 or $200 million spent in the last administration, again, on trying to reduce ED wait times, that didn't pan out with the results that people would hope for. That's 1,000 affordable housing units to be built in downtown Toronto. And so I think the thing that, hopefully in terms of a takeaway of lessons, is not to sit in a place of, I think you've seen that I err in a place of self-critique than celebration. But I do think to look at it in the view to say, we can no longer operate in the silos of healthcare if we're talking about health. And I think it's a real gut check for physicians, I hope, and different, nursing, social work, and other folks who work in the hospital. But I'm going to just call out physicians a little bit because of my own training. we've not always been on the side of progress. We've mostly been opposed to issues, even when it was universal health insurance, even when there were movements on various aspects. So I think the learning lesson from that sense, I think, is we have to take not only the dollar about value, about cost savings in effect, but the dollars that we're spending without real evaluation on what they're doing from health policy for patients, knowing that it's not just $150 million that may have had a modest effect on ED wait times. It's the 1,000 units that we're foregoing, and it's that grand scale of poverty, that grand scale of income inequality that we as a healthcare system are inadvertently contributing to. So I think if there's anything from my reflection of the past year, it is really to have that place of humility of where we are as a hospital, where as a healthcare system, on what actually contributes to health. And any progress is going to be about partnerships. But I think on the third, we really have to think about research and experimentation on the health policies that we put forward. I think that is a major piece. Everyone in this room is spending, I think, a Wednesday night because they believe public policy can change people's lives. And if you think about how much we spend on researching and evaluating the policies that have been put forward over the last 10 years, it's minuscule. It's not something we'd expect from a hospital. It's not something you expect from drug evaluation or therapeutic research. But that's what we've done in Ontario, and that's what we've continued to do. And so I think those are the pieces, again, of pushing back on where we think we're making real effects and being able to reconcile that with the broader and wider challenges of poverty, income inequality, and everything else that you so eloquently alluded to.
That's really helpful. Well, in thinking more directly about the audience and knowing that there's many people here who are embedded in the healthcare system, others in public health units, but we're also people who are living in Toronto, in Canada for the most part. Anyways, I don't know who else is here. But we're all sort of citizens of this society or other societies, and it'd be interesting to hear what you think about what the key messages are that you'd like to sort of communicate to the public. So given what you guys have sort of said, one is that you see this huge benefit from the medical system, from the healthcare system, turning towards not only acknowledging social determinants, but actually engaging and providing, in this case, housing to offset some of the sort of downstream consequences of not having those social determinants in place. And on the other hand, are sort of saying, look, it's not clear that this is the most scale appropriate solution. So I wonder if you could talk a little bit about that and embed in that sort of discourse. I mean, sort of what would you say to an audience like this about the work that you're doing, about your thoughts more generally about how it sort of fits in the broader scheme of things? And I guess the sort of other piece of that is how scalable are the things that you're doing, or should they be scalable?
These are the deep questions that we have to wrestle with. So thanks for guiding us to them. I'll pick up on something that Andrew alluded to, which I think is a great point. We in so many cases we don't even get healthcare right. Like only healthcare would have the hubris to be like, we're going to fix social dysfunction when we haven't been able to get wait times down so that people who need care can actually get care. So like that is a sad irony of what we're talking about. So let's just call a spade a spade. But I'm not a nihilist. I am an optimist. And I think it does lead us to a little bit more of what needs to be done. And I take my cues from, there's a great report published by the National Academy of Medicine in the United States earlier, actually in 2019 now, which was about integrating social care into healthcare delivery. If you haven't already read it, I really recommend it. It's a thoughtful compilation of a lot of what we're talking about tonight. But they offer a framework, which is the 5 A's, for healthcare systems to really, think about this. I won't go into each of the A's. They are awareness, adjustment, assistance, alignment, and advocacy, and they sort of cover that, that spectrum that I described earlier. But I'll pick out the second A, adjustment, which I think bears a little bit of a treatment here, which is, I think of as, they didn't have this in the report, but I think of it in the context of the famous Gandhi quote, to turn the spotlight inward. For healthcare systems and other healthcare institutions to really look at what is it that we ourselves have more direct control over that we should be doing differently. And so, so access to care is a great example. You know, for my patients in my clinic, I take care of restaurant workers and taxi drivers and housekeepers, people who are living in a cash economy, for whom taking a few hours out of their day to come and see me in clinic is a direct hit to their wages. You know, my starting point is actually to give them a hit on one of their most important social determinants of health, right? So let's acknowledge that and actually set up our systems so that people can access care better. And so we've elaborated a number of things that use technology judiciously to try to make it so that, you know, for my patient with diabetes who needs their insulin dose titrated, they can actually do it by text messaging a nurse rather than having to come in for multiple visits, you know, and take time out of their day. So things like that I put in the category of adjustment. But next to those are things like implicit bias training for clinicians in our system, and holding people to the idea of trauma-informed care. So these are all things that we have not made a firm commitment to in healthcare yet, but which are actually critically important to really infusing this idea of the social determinants of health in things that are actually far closer to the core bread and butter of what healthcare is responsible for. So, so that's one way to get at what you're talking about. But again, not to throw in the towel on the policy side of things. And I'll just give one other quick point on this, which is another one of the domains that I mentioned for our social determinant strategy is legal help for our patients. So we have one of the largest medical legal partnerships in the United States. And to me, it's a great example of being able to knit together from individual social needs to taking on really large policy issues. Some of you may have heard about a particularly pernicious anti-immigrant policy that has been elaborated by the Trump administration known as public charge, which basically forces immigrants who are lawful residents of the United States to choose between getting Medicaid with his health insurance. You know, imagine you're a 50-year-old woman with kids, and you have to choose between whether or not you're going to get your mammogram or whether you're going to disenroll from Medicaid and the chances of keeping your family together. Like, those are the terrible choices that are elaborated by this policy. And so we, through our medical legal partnership, had an ability to both help people very directly, you know, navigate their situations, but also sort of sublimate that into a more powerful advocacy. You know, we partnered with the New York Attorney General's office to challenge public charge in court and do things that allow us to sort of gather up those individual strands into raising our voice for things that are really harmful for our patients, but which are more on the policy level.
Sorry.
Yeah, I mean, I couldn't agree with you more on Dave, with the piece on, and I think that this is where there's been so much leadership in the room on turning that lens inwards from healthcare providers. And I think, as Professor Siddiqui laid out, you know, understanding and acknowledging the history of violence and the lack of cultural safety in our institutions and the process that's come forward for where we're at, I think, as hospitals, and the egregious acts that have happened over the last 50 to 60 years, if not longer, And I think being able to understand that inwardly, both on implicit bias, but understanding it's a confluence of things to how we have training and education within the hospital, and then also within the hope of where to see real diversity, of see different groups make up leadership positions that have historically been shut out and marginalized. So I think that is a massive piece as we talk about all these things, and so many of these interventions have to be based on trust and human dignity, and we have a humbling amount of work to do on that front. And I think that that's the piece where, again, we can't afford to be complacent on, given the damage that's been there. The other piece that I guess would get out in terms of the lens, in terms of the internal reflection, I think, and there's been some, again, to give kudos to other organizations who are doing this at a pace that might be farther ahead than where we're at UHN, but the hope that we're trying to build now is basically an outcomes unit for population health. And I think if you've asked senior leadership, where are the neighborhoods that you see the greatest inequities in outcomes or access? It's really challenging. I'd be impressed that anyone within senior medical leadership knows where that's happening. And if we could even identify 5 areas or 5 issues in terms of whether it's cancer screening disparities, larger disparities even about health outcomes, now that onus is on us to actually prioritize that patient population, prioritize those outcomes, and do so. We haven't leveraged the data that way, and some of it is because I think there's been a lack of good data, but I think on data that we even currently have by postal code, it hasn't been at the central and top of mind for organizations as of yet. And so I think that's part of the work as well, is how can we get at that outcomes and that disparities unit piece, and to push our own data analytics, to be pushing our own leadership to be saying, we haven't moved the needle on this convincingly. And how do we do that? And I think the piece that we've raised today in terms of how is it's not going to be us prescribing those solutions. That has to be in partnership with those neighborhoods and those communities who have far deeper insights into what's going to work on that trust. And I think that's where the lessons have been for me in the past year, both about how we have that awareness, but if we really want to see any real action, that has to happen in tandem.
That's great. Maybe I'll ask both of you to say something about your vision and your thoughts for the future. Where are you in the trajectory of where you hope to go with these efforts? And what do you see in terms of the broader context in which you're situated? What do you make of this moment in policy terms? And what do you sort of hope to see as we move forward from here?
You first, you're the guest, go ahead.
I initially thought I would leave this wonderful discussion with is the work is definitely not done. I think that's clear from everything that we've said. But maybe the vision to just point up is the idea that we will think equally about the patients we do not see as the patients that we do see. And for those of you who are in medicine, we use this colloquially when you're making rounds or taking care of patients in the clinic. You talk about seeing patients, and one of the things that really strikes me about this work, and that I think is really fundamental to the notion of population health, is to lift up to the same level our thinking about the patients we do not see because of marginalization, because of the way that our systems are organized, because of all of the factors that we've tried to just unpack a bit tonight. But let us sort of have the consciousness to take this on for the patients we do not see as well.
Thank you.
Yeah, I think, Dave, to your point on that, I think about that term that we use in medicine of loss to follow-up, and how we've systemically accepted that view. We even have a medical term for it, of where we as a system, whether in partnership with health and social care, have accepted and even codified it as something that is routine. And so I think being able to have that focus, whether it's your measuring of the outcomes, is definitely of huge value, and something that is a major shift, I hope, for us. And I think that, to the point, I think we're at the beginning really are, the hope is actually that we're at the beginning and that this isn't momentum that is lost. And I think that in terms of my reflections, I think that this has to be a coalition. This has to be work across multiple organizations, both within healthcare and outside healthcare, most obviously. But I think that if that doesn't come together, I'm worried about things becoming faddish. But I think the other piece is the urgency that everyone in the room has on what's happening on issues that we're trying to do on medical, legal, or housing. If an administration's major social policy is going to be $1 a beer, an increased alcohol policy, or it's going to be reducing social assistance rates for income, that is just devastating for what we're trying to do from that sense. And so it's got to be collective. It has to be a coalition of people in terms of where there's that advocacy that's happening, but then also that action that's happening in terms of us getting, hopefully, on the path to getting even healthcare right. And so I think that piece that I think we're starting at cutting away that hubris and encouraged about the start.
That's really helpful. Thank you. Well, I'm encouraged that there are initiatives happening within the medical system, within the healthcare system, but we clearly have people such as yourselves who understand the larger context in which that's operating. So to me, that's reason for some optimism. So we are going to turn the mics over to the audience after thanking both of you for your kind comments. We really appreciate it. All right, so we have some time for some questions for our panel. And I think there's microphones wandering around.
I suppose I'm the oldest person here, so I'll get the mic first anyhow. This dilemma, what we're talking about, the social determinants of health, and I'll just give you a bit anecdotal. Back about 20 years ago, 25 years ago, federal government had funded a project to some people like us, and saying for poverty reduction. It was very interesting. I sat there listening as part of the audience, and there had a lot of ideas and a lot of thinking and so forth. And so I asked them, because you have to understand fundamentally that you have to create wealth to distribute the wealth as well. You know, we have a lot of wealth we can distribute, but also you have to create wealth, and this related to the particularly First Nations community, and they were trying to reduce the poverty there. And I said, how are you going to create the wealth? And the individual man, one of the professors sitting there, says, oh, we have an economist on our team. And I say, economist crunches the number. He doesn't know how to create the wealth generally. Okay, he can give you advice and so forth, but they don't do it. So what really I'm trying to tell you, that all of these areas, you need, I think we are also, a lot of time we are called medical imperialism or health imperialism, that we encroach or we don't know how to create employment or reduce the employment or so forth. We have function there. I'm not saying that, but that we have to recognize that our function is to show the policymakers or public at large that the unemployment has these health consequences. And if you want them to really to understand that what is the dollar in value increase if we have that kind of unemployment. And back in 1992 here, we had employment of 12%. Canada historically, you're absolutely right, has a higher unemployment in the US has been. We've been always happy to for 5.6, 5.8. We were happy always, anyhow. And still that's what we are now. But the 12% we did some study. I got interested in
I
it.
might just ask you to wrap up a little bit so
Yeah,
that we can ask
okay.
some other people as well.
And what we showed that there was a $1.2 billion extra cost to healthcare system. Suddenly people were listening. That's what I'm trying to say. That what kind of things we can offer, and there are other things I think we might also encourage other people
Thank
to
you.
collaborate.
Thank you very much. Yeah.
Yeah, I'll just say
Yeah,
thank you
please.
for that very thoughtful comment. I agree. I'll give you two quick lenses in terms of my reaction. One is a personal one. My wife is a public school teacher, and I'll come home after a day of seeing patients in clinic, and she is a middle school teacher. She'll come home from a day of teaching middle school, and over dinner, I'll say, you probably did more for the health of your students than I did for the health of my patients today. And I really, believe that. It's not because I'm a terrible doctor. I think it's because of, it's because of the nature of the systems. And I think that's right, and I think it gives us an imperative to change healthcare, to be more pointed toward health, but also for us to make that connection, just as you say, between health and wealth, because for a productive population, being healthy is fundamental to to economic output. So it's something that I think we should be more deliberate about talking about.
Yeah, and I would just underscore the point, Professor. I mean, I think from Professor Siddiqui's work that's shown so strongly of the issue of income and health outcomes, but just this week there was the JAMA Internal Medicine paper about showing social mobility even within the US and seeing how devastating of impact that's there. So that really, we talk about deaths of despair, these are issues of where we've totally removed opportunities for people and then been surprised that they have worse outcomes.
Really appreciate that. Thank you. Others?
Hi guys, so I'm a human factors researcher and I look at kind of behavioral change at an organizational level. This is the context. So to your points, one thing I looked at was how to do sea change, this regulatory effort to standardize cardiology guidelines around obesity and health determinants nationally. So that was the challenge. And the question I'm asking is a concept, corporate social investment, where there was debates when we were thinking of not switching but moving towards a super agency of liberal rallies against the idea, and a TELUS group came over from Vancouver to pitch for it, saying that a company could help sort of standardize and leverage all the tools and resources they have to really attack these ideas. And I'm just curious from your multiple points of view, if the idea of having corporate interests or at least companies take on these issues where they can metricize it, turn it into KPIs, and attack it that way has a strength to fix these problems from your experience, or if it has the issue of maybe making it too insular, too specific to those companies and those sort of buckets and silos.
Pointed to me as a skeptic. Thank you. Without getting into market views or things on privatization and not knowing the specific case, I think the hope, back to ending on being hopeful, I think on the point of being, there's hope that I think that the movement has come that even when you talk about this issue like data, being really clear about who owns that data and these issues. And I think that we've not had the accountability and frameworks with private industry. We've done so. We've seen examples even currently in the US, and of course let Dave speak to whatever piece, but as we've had these experiences in Canada and issues even around people's access to their own data, it's been a travesty in that sense. And I think that and again, not to have anti-industry, but I think as you go into views, even when it's for us as physicians engaging with industry, we don't even have transparency or conflict of interest guidelines or disclosure. The same thing as when agencies go into private industry views, those conflicts have to be disclosed. But also just the major piece for us working in the public sector is that protections have to be in place for patients and people and citizens. And too many times in whichever sector, there are countless examples of where that has not happened. And my hope is that whatever the views are in partnerships with industry, and that might be great and fruitful, and we hope for that in terms of creating wealth and more equitable wealth, that's the fundamental principle and starting point, that isn't lost.
I would just add, generally I'm a pragmatist, so maybe it's better than not having the corporate social investment that you're talking about. But to me, it really runs into this really important conversation around generosity versus justice. And it's, on the generosity side, it's not just corporations, but also philanthropy, where we have to just be careful that we're not settling for papering over unjust systems and approaches, right? So if corporate social responsibility or some philanthropic investment is the only solution to the entrenched social problems that we're talking about tonight, then that is not enough. And I think we have to keep our eyes very wide open for that being used as an excuse for insufficient public investment, insufficient government regulation, and just be aware of that.
Thank you, guys.
The cynic in me says they don't really care. So how do we turn it around so that they do care? So there's the decision makers. We see that widening. We know who is at the bottom, but it doesn't really matter because of who is at the bottom. So that's the cynic in me. But the other side is that do either of you think we really have a chance of making these changes without two things? One, we get over ourselves and we actually begin to have the data. Health says, you need data to make decisions, but then we can't get in Canada the collection of sexual orientation data, race-based data. We get all the academic arguments why not, but we can't do it without that. And that decision-making tables, we actually see change so that Black and Indigenous people are at those tables. So do you think we have a chance without those two things happening?
No.
No.
Very well said.
No chance.
Indeed. Hi, I'm a resident doctor in family and emergency medicine, but I came to medicine from a public health heart. So thank you, I appreciate that comment. My question is around the concept of health and all policies. It's a concept that's been around for over a decade now. There's been a renewed call for it recently in the Canadian Medical Association Journal just this past week around calling for health and all policies. Be curious to hear your thoughts around that concept, whether that would help us sort of reorient some of our systems or whether that would just be going down the pathway of more health imperialism, as our other commenter had said.
Yeah, I've thought a little bit about this. I'm not sure I have any really good answers for you, but it feels like an example of hubris to me. Like what other sector says education in all policies, energy in all policies. So there's a little bit of that gives me caution about maybe the framing of it. But the substance of it, I really believe in, which is that if we take, again, the framework that Professor Siddiqui showed us, it is true that we have this complex interplay of all of the different parts of our society that generates health or illness. And so we, it's sort of a natural consequence of if you buy into that, then you have to be willing to partner with other sectors in co-producing health with them. But I worry a little bit about how effective a framing of health in all policies is to get those other folks on our side. So yeah, like I said, I'm not sure I have an alternative to suggest to get to the substantive underpinning, but that's a little bit of what I worry about with the framing.
Yeah.
What do you think, Andrew?
This is strange. I'll be more positive. No, I think it was great to see the publication this week by Tonelli and others around this issue that's been around, as they state, about how long health and health policies, or HIAP, has been in the discourse, and now what's the action plan. I think it's a great move. Actually, on the imperialism piece, I'm less worried in health and health policies, because I think if it's a collective social decision that the outcome is health and happiness, or whatever the well-being piece is, then you need, with that complex interplay, different sectors and ministries and folks together to have that outcome. But I think that, to me, the biggest issue is when we've looked at measuring our success as a nation, it's been GDP growth. And I think that's the change that I think we fundamentally need to see. If it's a shift from GDP to health and well-being in budgets, which we've seen in New Zealand and other places doing, I think that's really a progressive view. I think the challenges have been, even if you look at experience in a place as vast as the Ministry of Health, or healthcare, the fact that even the drug budgets don't speak to the hospital budgets and other pieces of home care, that there's so much silo or fragmentation happening. It's hard to believe that this can all happen within Ottawa or the city or the province. But I think it is fundamental to making better investments. We've seen this before. If you just, it's this complex interplay. If you inject a bolus of money into the healthcare system, it's not translating into sort of health outcomes you've spent on it. And so going down that path continuously, I think, is just inane. But the hope is that if we can actually start to think of ourselves in the Ministry of Health, folks who are working there, as insurers and thinking about this and what are the outcomes going to be, and if the outcome is health and not just getting X amount of X-rays or MRIs, or this is the waiting time metric, if we can change the metric, I'm hopeful that maybe we can actually get to a better structure that enables health and health policies. Right? That's the hope.
Can I say two other things on this? But before I say that, I hope I'm not out of turn here, but Professor Siddiqui, you should also, you're like more expert certainly than I am on most of this stuff, so please feel free to jump in and do better than us.
Unlikely,
Well said. Well said.
but go ahead.
I'll say my two thoughts that I have on this point, though, which is first, to give you sort of the American perspective on this question. Health and all policies feels like a Canadian dream to me. I would be happy with health and health policies. Right now, the state of the healthcare debate, the health policy debate in the United States is all about healthcare. Not even about healthcare. It's about coverage. So on the right, you have people who want to continue to repeal the Affordable Care Act. On the left, a war between those who are proponents of Medicare for all and not. And then, for those who are like, well, where's the health in all of this? It is, again, back to the framework, like the other 80% of what we're talking about. So, to give you the south of the border view on that. And then the second thing that I'll say is maybe to challenge us a little bit, though, because we're sort of, I think, being a bit lazy in talking about being able to measure health, because we use these proxy measures like life expectancy and mortality. And I don't think, and again, I'm sure there are people who are far more expert than me in the room on this, but I would say that we really need some summary measure of health that combines mortality or life expectancy and quality of life, to get to what really matters for people when they think about their own health. And so even though I'm right up there with people who are pointing out, look, life expectancy in the United States falling for 3 consecutive years, red alarm bells, something you can hang your hat on, something is really going awry. But if we're being totally honest with ourselves, it's the responsibility of folks like us in this room to actually come up with a better way of measuring health, and that will actually make it feel more relevant to our neighbors, people who don't think about this every day. Because life expectancy is most people want to continue living, but that is not really what you can grasp in your hands about health, right? So I feel like that's on us.
So maybe I'll just say a couple of short things. One is that I think it's fine within public health circles and health system circles to use health in all policies as a way of reminding ourselves and advocating for policies that we think affect the social determinants, and acknowledging that that has to be a central part of moving forward an agenda to create health and health equality. Where we may fall short is if we stay in that framework and don't acknowledge, as Dr. Chokshi said in an earlier answer, we could have energy in all policies. In the Scandinavian countries, they have children in all policies as a central part of their government, which there's nothing wrong with at all. And I think what's most important is some central recognition of what it takes to live a good, decent life, what the role of government is in that, and what the trends have been, some awareness of where we are today, what the trajectory has been over time, particularly over the last several decades. So if health in all policies helps with that, terrific. And at the same time, it probably does require a broader coalition and a broader awareness of the centrality of those policies for a variety of outcomes.
So, thank you. May you share one recommendation that would equalize the decision-making powers to give more distributive power to people or sectors, even acute versus non-acute, different racial groups who are historically disadvantaged, more power moving forward to create meaningful partnerships and meaningful change?
Please.
Very good question. One recommendation. I think so much flows from money, from how resources are distributed. I think this is more to get at sort of the question of sectors rather than representativeness, within the power structures that make decisions. But to try to equalize it better across sectors, I would say that we have to be very upfront about how much healthcare is cannibalizing other parts of the economy. And we see this at an individual level as well as at a macroeconomic level. At an individual level, it gets back to what I was talking about in terms of turning the spotlight inward. In the United States, the leading cause of bankruptcy is medical debt. We have to name and confront that and say that is our responsibility from the healthcare sector. And then at the macroeconomic level, you see it in city and state budgets, how much the inexorable growth of health spending has eaten into all of the other sectors. I keep pointing to the framework. Instead, you see our photos up there. To the WHO framework, where we're chipping away, at the resources for all of those other sectors, and particularly education budgets, because so much of education budget, because it's a very labor-intensive profession, the growth in healthcare costs means that for the pension liabilities and just the health benefits that are associated with that continues to shrink and shrink the actual resources that are going toward education. So that's what I would say.
Yeah, I would just say it's the same on socioeconomic inequality, but I'd also get at, maybe it's a bit more on measuring what matters for people and for patients. I think, the example that I'm thinking of is with the recent New England Journal paper on what we're going to do in the healthcare system for patients who have suffered 40 to 50 years of poverty and have been sick. We're going to throw 3 to 6 months of healthcare interventions, and guess what? We're going to measure success. It's going to be hospital rate measures, not even 30-day hospital readmissions, 180 days. And that's going to determine whether it's a success or failure. So I think, no patient would say that that's actually a metric of success, is ED visits or hospital readmissions, but that, even in the world's most prestigious medical journal, is how the New York Times then captures, or the efforts, success or failures. And so I think if that lens goes through and has behavioral insights to all of the decisions within public policy about whether it's how you better capture health and quality of life and well-being, if that could permeate, I think it's a big step.
I think we have time for one more question.
Great, and thank you. And I know when I'm listening to you talk, you're talking about government investing in this movement. And I've been an entrepreneur for 30 years. Getting government to invest is incredibly difficult. It means that people have to accept that maybe we haven't done things the best way, and then in lies your moral dilemma. So I'm looking at all the people and all the young people in this room today, and we've all just been through 2 major elections, both provincially and federally. So why wouldn't you play the same game that the politicians are playing and create a social movement that they can't ignore? And a social movement that attracts philanthropy and creates a movement of people wanting to support people and shame the government into making their contribution and declaring it in their election platform. Because I just think all we're going to keep hearing now is there's no money. And there is no money because we have a huge deficit, but you have to shame them into finding the money. Just a thought.
Well, I can't speak for the Canadian political system, but as the ambassador to Canada, what I can say is really to pick up on where Professor Siddiqui left off with her last slide, which was pointing out inequality. And so first of all, I would challenge the notion that the money does not exist, right? The money exists. You saw, particularly in the United States, the per capita income has grown significantly. But that is tied to the point about inequality. One thing that we didn't talk about explicitly is there is growing income inequality as represented by the Gini coefficient increasing over time. There's far more significant wealth inequality, and this is a distinction that is critically important, particularly when we're talking about intergenerational transmission of illness and inequity. So in the United States, the top 10% of the population holds half of the income. The top 10% of the population holds 3/4 of the wealth in the United States. So the resources exist, but your point is very well taken. All of that is not going to change without a social movement. And so hopefully we've started a little bit of that, or continued it this evening. But I think you're actually seeing it in the winds that are shaping the United States presidential election as well. Particularly the enthusiasm for Bernie Sanders and Elizabeth Warren. And we're living in a very polarized time in the United States. So I think we will see if the generational shift. You're right to point to the young people in the room. I think if that is going to be enough, if people feel outraged enough and motivated enough to change and to turn on its head the maldistribution that we have today.
We need a hashtag.
And I would think even more than a hashtag. I think the simplest, and I think that the social movement is bang on, but I think in the sense that I think we've talked about the social determinants of health, I think the piece to get to social movement, to Connie's great point, I think it just has to be a clear question and one that can no longer be avoided and shirked, which we've done and we've discriminated against whichever population, so forth, is bearing the brunt of the racism and discrimination. And I think the question is to be, we as a nation, will we accept
where someone lives, whether it's our cousin, it's our friend, it's someone we don't even know, differences in health, in life expectancy, in life, depending on which postal code you have in this country, and whether you live in the north, whether you live in the city, where you live in the city, how long are we going to be willing to accept that difference? And I think that's the clear question of policymakers, and that people have to press them on. I think they like to get esoteric with, well, it's complex and different things, and it's going to cost money. This is the reality we currently live in, and we as a country are going to accept it, and if we do, we've continued to accept discrimination against certain groups, and mainly groups who